We'll just give it like one more minute since we switched up the link on people last minute.
Greetings, everyone.
Hello. All right, we'll go ahead and start. I don't want to take up too much of your time, Rosie. I'm sorry. So I'm on the road, so if I cut in and out, I apologize. But today we have Rosie as our special guest speaker, and Rosie works for VDH and has her MPH and is a state forensic epidemiologist for Virginia. Rosie was born and raised in Reno, Nevada, and received her undergraduate and master's degree from the University of Reno, Nevada. Rosie moved to Virginia in 2013 for her current position as the state forensic epidemiologist within the Virginia Office of the Chief Medical Examiner. She has worked on a variety of different mortality topics in Virginia. However, much of her time over the last several years has been focused on tracking and reporting on trends in fatal drug overdoses across the state due to the opioid epidemic. Thank you so much, Rosie, for taking time to talk with us today. And we're all really excited to hear what you have to say about working with the chief medical examiner.
Sam, thanks for having. Oh, go ahead.
Yeah, no, I was gonna say I'll hand it over to you.
Yeah, thanks for having me today. It's exciting. I haven't presented in a little while, so I always like talking to schools and students and stuff. So I'm going to talk to you guys today about an epidemiologist's role in the OCME. When I started this job a little over 10 years ago, I was one of only a handful in the country of epidemiologists that worked in medical examiner or coroner systems, but it's become more popular, and I've been able to work with other people across the country in the same profession. So I'm going to talk to you guys about what I do, and let me go to my next slide. So today's objectives is I'm going to describe the work of the OCME and what we do as an office. I'm going to talk about why the OCME is important and the data that we have is important. I have worked on a variety of different mortality topics, from homicides, suicides, child deaths, a variety of different things. But I started with the drug overdose stuff, and that's just been the common theme throughout my position. So I'm going to talk to you guys today about drugs and some of the different trends that we've been seeing over the last 10 or so years. And then I'm just going to close with discussing my education path and some recommendations for students on how to transition from education to a career in public health. So here's an organization chart. We are a state agency that falls within the Virginia Department of Health. Our state health commissioner is Dr. Shelton, and these are all the offices that she oversees. You can see that we are within the population health and preparedness, and we are one relatively small office that falls under that subsection right there. Our chief is Dr. Gormley, that oversees all of our 4 offices. So some of the staffing roles we have here at the OCME. So here's our regional map of the different counties that fall within the different offices. We have a central, northern, tidewater, and western office. And our state team is co-located with our central team here in Richmond. So between those 4 different offices, we have roughly about 110 staff total. We have 1 chief medical examiner who is the head doctor for the entire state. Right now we have 11 board certified forensic pathologists, which we call the assistant chief medical examiners. I think we're accredited up to 17. We're still looking to hire more, but these are all the doctors in our office that perform all the autopsies and examinations, court testimony, and do all the investigations for the deaths that we manage. We also have about 30 or so medical legal death investigators. So these people are have bachelor's or master's degrees in forensic science, and they manage all of the calls and the deaths that come into our office and get medical records and do investigations. So do scene visits to see deaths and document, take photos, variety of different things. We also have autopsy technicians, about 15 or so statewide. They assist the doctors in autopsies, as well as doing like microbiology testing submissions, toxicology testing, a variety of different other things. We have a few different histologists across the country or across the state. And these people do like get the slides ready. So when they take tissue sections, they'll embed them in paraffin wax um, and then send them to our doctors so they can look at the pathology. We have one epidemiologist, which is myself. We have a district administrator in all 4 different offices that run that specific office. A variety of different administrative support staff, which help with paperwork, phone calls, records requests, record release. And then we also have the Division of Death Prevention, which I'm going to talk about a little bit later, but this is a group of people that look at specific types of deaths that we manage and do deep dives. Your analyst staff, we have programmers, researchers. I now think we're about to just hire an epidemiologist over there to oversee a couple different programs, but it is one little branch of our office. We also have embalming and administrative staff for the Virginia State Anatomical Program. This is the bodies donated to science. So they prep those for placement in different schools to do anatomical dissection. We also have roughly about 120 or so local medical examiners across the country or across the state. And these are not people that are staff within our office. They're more so licensed health workers in the counties under contract to do to manage individual cases on a case-by-case basis. And those healthcare workers can be MDs, DOs, nurse practitioners, and PAs. So what's the mission of the OCME? Well, there is a quote that the dead shall teach the living. So we conduct medical legal death investigations for deaths that fall under OCME jurisdiction. We do the post-mortem examinations, whether that's an autopsy or an external examination. We certify the cause and manner of death on the cases that we manage. We provide medical insight and findings in court proceedings for typically criminal cases, homicides. We do the testimony from the medical piece. We educate peers and professionals on subjects related to death investigation, a lot of training that has to go on. We have a mass fatality planning component. So if a mass event of deaths occur that's due to unnatural causes, like for example, a plane going down, we will be managing those bodies and those death investigations. So that can be very overwhelming for us. Just if you think about a plane, 250 people or so, it's a lot of effort. So we have a mass fatality planner here in our office. We provide statistics on unnatural deaths in the Commonwealth, like I'm doing today. We have reduced violent death by conducting surveillance and fatality review projects, which is what I just mentioned on the previous slide. And then we administer the state anatomical program, which is, again, the bodies donated to science. So just because you die does not make you a medical examiner case. I've had that question a few different times, but here's the criteria to become a medical examiner case. Well, first off, the death must have occurred here in Virginia. The best example is we have a lot of out-of-state residents that die in motor vehicle accidents. California residents driving, sightseeing, and they come and die here. This is a little bit different than what the health department does because they base all their stuff on residents, but obviously it doesn't make sense for us to do that. So there is some difference there. And then we take everything that's due to an unnatural cause of death. You're going to hear me say this multiple times throughout this presentation, but unnatural cause of death is anything due to homicide, suicide, or an undetermined manner of death. And so trauma, injury, violence, poisoning. We take people that are in custody, prison, jails, people in process of being apprehended, state mental health facilities, and really anything that's just not a clear-cut, like heart disease, cancer, kidney disease kind of death. And so statistically, here is a graph of just the number that we take per year. So in black right there, that's the total number of deaths that occurred in Virginia, all deaths. You can see the increase in 2020, 2021, and 22 because of COVID. But the line in blue is the cases that we took as medical examiner cases. It's very roughly about 10% per year. So the other 90% that you're seeing are natural diseases that do not need a forensic investigation from my office. And the line in red are the ones that we certified as an unnatural cause of death. Again, accident, homicide, suicide, or undetermined. And you'll see kind of some cutoff different timelines on my slides just because we do have some timing issues about how long it does take. Some death investigations can take a few days, some of them can take months, some of them can take up to a year. So in pretty complex cases. So you'll see some kind of cutoffs with some different time elements here. So what's the step-by-step process of death certification? Well, someone dies and hospital, law enforcement, whomever calls our office and reports that death. We look based on code, look at the circumstances of the death, medical history, a variety of different things, and we determine whether we're going to take that as a medical examiner case or we're going to turn it down and they don't need an involvement from our office. We do the exam and send out any necessary specimens to help with cause of death, toxicology, microbiology, heart studies, brain slides, a variety of different things. And then we will issue a preliminary autopsy report and a preliminary death certificate. Once we get all of our testing back in and all of the reports, law enforcement reports, everything, our doctors make those, take all that into account and determine a cause and manner of death. And then we issue a finalized autopsy report and death certificate, and then that's where the statistics begin to be calculated. And so we have two kind of big two sources of data in my office. There's me, a solo person who does forensic epidemiology. I do look at all the cases that fall under jurisdiction of the OCME, again, that 10% of deaths. It's the deaths that occur in Virginia. It's based on recent data, and it's restricted on details collected during death investigation. I say I answer the who, what, where, and when question, but DDP has risk factors and the why question. And so the DDP has two different types of projects underneath or in their division, surveillance and fatality review. They're on a very specific set of OCME cases, like they'll do child drownings or child or maternal mortality or very specific types of deaths. It's only residents of Virginia. They are very behind, about 2 years, but that's because they have a very strong data collection on risk factors, contributors to death. They go through each case and extract all the elements that they need to build this is kind of how this person's life laid out, the risk factors, circumstances, past history, it's a variety of different things. So as you can assume, it's not a quick process, but it's very comprehensive. And again, under the Division of Death Prevention, the surveillance projects and fatality review teams that we have are listed here. Surveillance projects are essentially grant-funded federal projects to put or extract data from deaths and put it into a database and then make reports based on that into a federal database. Fatality review teams are a bit different, and I will note that we only oversee the state teams. There are local and regional teams. We are not involved with those, but we're only the state teams. But fatality review is essentially a group of multidisciplinary people across Virginia come together and discuss a subset of cases, 6 to 10 or so cases, and look at this person's life from when things started kind of going south up until death, and they make recommendations as a team about how to make or prevent these deaths moving forward. This can be, there's a variety of different people, obstetricians, law enforcement, behavioral health, just a big, large group of people. And the teams are listed there. So here's some of the elements that we report on for the medical examiner's office. I do want to notate that there is a difference between manner of death and cause of death. And this is also going to be different than vital statistics. So we are very unique here, but I want to make this explanation first because it's going to be talked about throughout the presentation. But the manner of death is essentially intent, to boil it down. And we group those into 5 with fetal death is other certain circumstance. But the manner of death, again, intent, accident, homicide, natural, suicide, or undetermined. And then a cause of death is what that person died of. So you could have, gunshot wound homicide, you can have an accidental fentanyl overdose, you can have a hanging suicide. We certify those 2 different things on our death certificates. We obviously report on demographics, age, sex, race, ethnicity, and geography is a good one. These are exact locations of death. They're based on where the person resided, where the event occurred, and where the person died. These can be all 3 the same location, or they can be all different. You can be a California resident that got in a car accident in Fredericksburg, was transported to MCV, and died there. And so we do some geolocating with those elements. We have a variety of, it's kind of had to be kind of vague with this because there are it's trying to encapsulate a whole bunch of different things, but various elements pertaining to circumstances of death. Types of gun involved in homicide, suicide, or any type of gun death, really. Types of motor vehicle that are involved in motor vehicle collision related deaths. Places where people are sitting in a car accident. It's just a big lump of the things that we collect. We also have a group description of location. So someone could be, die in a river. They could had a heart attack at a medical institution. So that kind of helps to distinguish some of the different elements. And then toxicology, which we're going to talk about here. And so who uses our data? So death is obviously the worst case scenario. It's kind of what makes headlines, unfortunately. And so we give a lot of data to a lot of different people for a lot of different purposes. Here's just some of them here. General Assembly, we give out data to pass laws about, a lot of different topics. Law enforcement to reconcile records. The public reaches out a lot. These are just a couple state agencies I've worked with, but a variety of those federal agencies that I've worked with. Sorry about that. And then the media is probably the biggest one. We get a lot of requests for stories that are going to be featured in the media, news, TV. And so what's the OCME's role in public health? So again, death is one of the key indicators of a community population. So when you look at death as worst case scenario, you can look at a variety of different other things in conjunction too. Are these people sick and not dying? Are these people, not sick and dying? It's just one of the pieces that are a key health indicator. And like I mentioned before, we generate a ton of very, very detailed data to provide it to stakeholders and partners and anybody. This is used to help target prevention and treatment efforts. I'm going to use like the drug stuff just because I'm presenting on it. But when you have different demographic differences between different parts of the state or different ages or drugs or whatever, it really helps with prevention folk to target their interventions to the people that need it the most. Collaborate on key issues like the fatality review, like I was mentioning, the multidisciplinary teams that review deaths. We share data to give a more complete view of the problem. We have a couple different dashboards out there where we're just one piece of a whole bunch of different things. And then emerging trends. And then we do a lot of, I get subpoenaed a lot for information. So there's just a couple listed there. And I do have another very tiny part of my job that's involved in cases of public health concern, like meningitis is a good example. We'll get somebody, whether we know or not, at the time of death, we'll be doing an autopsy and they'll crack the skull and they'll have, green everywhere. And so the doctor calls me and we have to, do case contact, call the health department and the local EPIs to do case investigation, case tracking. In many circumstances have to facilitate CDC testing. We have the state lab, which we submit a lot. They're excellent, incredible lab, but due to the kind of how we process specimens, like I was saying, like embedded paraffin embedded blocks, the state lab can't test, so we have to outsource stuff to CDC, so help facilitate those testing. Okay, so getting into some data here. This is the data that's from our database, and I'm just going to share with you some different trends. And then I think after this, we're just going to transition straight into drug overdoses and just some of those interesting statistics. So this is OCME data, and you can see the different trends here just by manner of death. This is not taking into account any causes of death, but you can see that especially like right around here is big increase in accidental death. And I don't know if anybody knows, but a lot of that is due to the drug overdose epidemic. It was actually started increasing right before the pandemic, and we're going to talk about some of the reasons why, but it has kind of exploded. I'm hoping that we have a decrease this year. We still have a handful of preliminary cases, but that's an overwhelming number. I always just like to point out homicide statistics just in comparison to other things, just because it provides some context, and there's just an interesting point in the different rank orders. And so the top 3 methods of unnatural death in Virginia, this is the same as national trends, and they are broken into drug overdoses in blue, and firearm-related deaths in red, and motor vehicle collisions in orange. These are all manners of death. So, it's drug overdoses of accident, homicide, suicide, undetermined, and that goes for all the other different categories. But I do want to bring your attention to 2013. It was kind of a pivotal point in the opioid drug fentanyl crisis that we see now, and there's a reason why. And so I think everybody kind of probably has a good comprehensive knowledge that opioids have been abused for years, decades, generations, starting from opium dens into the drug crisis in the mid-90s to late 90s with heroin, and then with Purdue Pharma putting out some of the oxycodone pills and all the problems that came. But I'm not going to talk about that. I really want to talk about the fentanyl crisis specifically, because that's when this started in that pinpoint on the graph in 2023 or 2013, excuse me. And so if anybody's heard about the Silk Road, it was essentially this Amazon platform, basically, where you can order your drugs and down the road other things, guns and a variety of other stuff. But it started out as a drug platform. And so people could order their cocaine, their methamphetamine, their fentanyl, whatever, and have it shipped directly to your house via the postal service. And it was anonymous, because if you look up here, it was on the dark web. And so you just download this browser, you'd be anonymous and be able to put all your information and have your stuff shipped to your house. It was very problematic. It started with the platform went on in 2011, or opened up. It was taken down in 2016. But ever since then, other platforms have popped up. But this was a big issue, especially where, or the things that was getting distributed, and kind of brought attention to a lot more other drugs. It's a really good book, American Kingpin, highly recommend if you guys are interested. There's some other interesting podcasts out there that talk about this too. And
Can I ask a question? I'm sorry.
Yeah, definitely.
So I see it just says number on the side. So these are just the counts. It's not like a rate for population, right?
No, I was just doing big picture for this.
Yeah. Okay. I just wanted to see what we were seeing.
Yeah. Oh yeah. Sorry. Everything's going to be numbers. I didn't do rates for anything. So
perfect. Thank you.
Yep. And so now transitioning straight into drug overdoses. Again, this is the data from our database. Over time, drugs have gotten to be a little bit more complex, or counting drug deaths, because there's this polypharmacy problem. It's not somebody we do have people that die of one drug intoxication, one single drug, but it's really this polypharmacy kind of thing. We'll have, cocaine, fentanyl, heroin, meth. We'll have all these different things. So you kind of have to count the drugs that are involved. And then also, just because something is present doesn't mean it was involved in the death. It could be, a prescribed medication that's in therapeutic ranges. And so all of our doctors interpret all that toxicology and determine which drugs were involved. These are the biggest categories. We test for well over 200 plus different drugs, but we're trying to look at the most frequently occurring drugs. And so these are the different classes. Benzodiazepines, those are CNS depressants, essentially your alprazolam, your things that, anxiety kind of medications. Everybody knows what cocaine, fentanyl. We're going to talk about fentanyl, heroin, meth, prescription opioids. There's a variety, big class of those. We're going to talk about that next. But you can see the big trend right here is fentanyl, and right here. So personally, the best way I like to look at the drug death is just opioids versus non-opioid overdose deaths, and kind of tease those out. So ones that involve at least one opioid and ones that have no opioids involved. You can see that it's although the non-opioid deaths are increasing slightly, it's really, the growth is really in these opioids. And so what is an opioid? Well, it's a drug that originates from natural, semi-synthetic, or full synthetic sources. And opioids is the overarching term. Opiate specifically falls within that, and that's specifically for naturally occurring opioids, typically from poppy plants. You can see some of the drugs that fall into those categories there. And so the opioids bind to the opioid receptors in the brain and block or dull pain, but also releasing feel-good chemical dopamine. Opioids can be produced by pharmaceutical companies with obviously regulation, and one pill is the same here as it is the same here as the same here, but there's also illicit production. Prescription opioids are often prescribed for surgery, pain management, end-of-life care, a variety of other different reasons. And among the illicits, the potency varies very widely. I think it was like 2016, 2017, they started coming out with all the different analogs, fentanyl analogs, and some of those were they were used, but the carfentanil was one of them that was being used to be a tranquilizer for elephants, and it was in the drug supply. So we had, I think Ohio got hit the worst by that, but we had a couple of those cases, very, very lethal. And so tolerance builds up quickly and can be extremely addicting. When you take opioids, it slows your breathing and your heart rate. And the naloxone and naltrexone, that's the chemical names, aka Narcan. So if someone's overdosing, those drugs bind to the opioid receptors in the brain to prevent the opioids from binding and thus getting someone out of an overdose. However, Narcan has a shorter half-life, so if you don't give enough or get them to the hospital, they can begin overdosing again. So sometimes it's multiple doses. So some of the categories of opioids that we look for, that's a list of prescription opioids that I code for. And then the illicits on the right-hand side, you'll see that fentanyl falls in both categories. And to this day, we still have a couple prescription fentanyl overdose people, typically that are, eating or chewing on a whole bunch of prescription fentanyl pills. Doesn't happen very often, but there still have a couple every year. But the fentanyl is really when it started emerging. We started seeing it here, the illicit fentanyl in 2013, and then it's just grown astronomically. The fentanyl analogs, I didn't put a slide on here because there's a variety of different ones, and they really changed over time. They were making these analogs due to different synthesis of drugs, as well as to evade federal scheduling laws. So if the law only says you can be arrested for fentanyl, well, you have this analog and that's not in the code, so you can't be charged for those crimes. So we saw a lot of those. We're now, over the last probably few years, there's only been 2 different ones that have just been regularly circulating here in Virginia. And then we also have these nitazene compounds. Those are very concerning too, very lethal in small amounts, or potent, I should say. There's a variety of different ones, even more than on this screen. They were made in the lab in the 60s and never really went anywhere, and now they're showing up again, so it's concerning. And so this is a graph of just the proportion of fentanyl involved in overdose deaths. So taking the total overdose deaths for that year and then just the proportion that involved fentanyl. And you can see in 2017, it's about 7%. We had far fewer deaths. So Again, this is proportions per year, so just taking that into account. But you can see that 2013 is when fentanyl started showing up. It was late 2012, early 2013, and then those numbers just continued. And then this year, even though we don't have all of our data, I'm estimating about three out of every 4 overdose deaths involving fentanyl or analogs, and that's kind of been the trend for since roughly about 2020. And just to talk about the lethality of fentanyl and different fentanyl analogs, this is I do this graph every year, and it's pretty interesting. So on the left right here, this is seized drug stats. So if someone is driving and gets apprehended or pulled over by law enforcement, and they have a powder or whatever on scene, law enforcement will confiscate that drug and submit it to the Department of Forensic Science into their drug seize section, and those drugs are tested. And so this is just representing of all seizures in 2022. About 16% of them tested positive for fentanyl. I'll just notate that this is illicit synthetic opioids. So it's mostly fentanyl, but there might be a couple other ones that are in a different category or a different drug. But on the right-hand side, this is just the drug deaths with fentanyl or fentanyl causing death. So you can see that although 16% of submissions of seized drugs were found, over 3/4 of overdose deaths involve fentanyl. So it should just show you, there's a lot of other drugs out there, but fentanyl is really what's killing everybody. And then just talking about the lethality. I'm sure probably everybody's seen this graph before. This is a lethal dose of fentanyl right here. It's, like kind of just a couple big, large salt chunks, basically. And you can think about how scary and concerning that is just in the drug supply. And then if you look on the right-hand side, those are just the different lethal proportions of heroin, and then carfentanil, that one I was mentioning right there, that one's in the middle. That's the elephant tranquilizer, and then just fentanyl, the last one.
Do you know, Rosie, if that's like the normal dosage of like fentanyl that's like in drug supplies, like the normal concentration? Or
we've seen, well, so the problem is with tolerance too. So people can get, if they're a frequent user, their tolerance goes up. So it's not a lethal dose for everybody. But there's another slide after here that I'm going to show you. It's pretty interesting about the illicitly pressed pills. So I'll mention that on the next slide. I'll talk a little bit about that.
Sorry, I was like, it shows 2 milligrams and like that small amount. Is that normally like how much it is though? Like, not like the amount, but like normally it's like a 2 milligram like concentration. Do you know what I'm saying? I'm sorry.
Yeah, no. Are you saying like for like it being lethal, or is that like the common amount that we see in our toxicology of deceased overdose?
Yeah.
It kind of varies. We've seen higher concentrations. Obviously, it's if they have other drugs involved, if they have heroin too, which we saw for a while, or other opioids. You can have a smaller amount of fentanyl and, have also oxycodone or whatever in there. And then those 2 opioids, result in your overdose death. So it's really kind of in context of other drugs, but I've definitely seen it higher in solo. I've seen, and it's crazy. And then there's a reason for that, especially around all the illicitly pressed pills. This slide right here is for Customs and Border Protection, and they put out these stats every month. And this is just of the fentanyl that is seized at the northern or southern borders stations. And so you can see that in 2021, there was like 11,000 kilograms, in 22, 15, in 23, 27. And so I think it's probably looking similar this year so far as what we saw last year. But, just with the increase in it being flooded into the country, you can just see the deaths going up so substantially. And a lot of that's attributed to these pressed pills. And so this has been going on for 5, 6, 7 years. years, but the DEA put out a publication a few years ago about how concerning it was. I think that one was really up for Northern Virginia and DC area, for how much it affected, but it's really kind of all widespread. And the problem with that is these illicitly pressed pills that they're making look identical to, your standard pharmaceutical pill. These oxycodone, these M30 tablets right here. This is authentic. This is the fake. It's indistinguishable. So people think that they're getting, they think that you're going to go on the streets to get your pills. They look the same, but it's rather than your oxy pill, you're now getting fentanyl. And the biggest problem with this is right here. And so when they make these illicitly pressed pills, they have a filler substance that they put, and then they mix the fentanyl with it. Pharmaceutical companies, when they do that, they're obviously regulated. And so your one pill, let's just say it's 10 milligrams or whatever, we're just going to use that. Everything is going to be 10 milligrams. It's required by law. It's overseen by, FDA. So you're getting, everything is regulated. But when you have these illicitly pressed pills, they're making these things, these in big batches. And so they have their mixture and their fentanyl. And so some of your pills, if they're trying to go for 10, you might have 100 milligrams of fentanyl in one and 2 milligrams of fentanyl in another. There is no quality control. And so it's not evenly distributed. There's, they've confiscated, a batch of pills before and done testing. And some pills are much, multiple times lethal compared to other pills that really don't have much fentanyl in them at all, or and then not even, people are trying to go look for some other substance, but it ends up being fentanyl. So it's just flooding the market. It's everywhere. Seeing some stuff about it was used in vape pens. I've seen it been put in Flonase, the things that you stick up your nose, like for seasonal allergies. Read a lot of different things. It's everywhere. You can buy it as a powder. You can inject it. It is because it's a white powder. And so just want to be conscious of time, but I just wanted to, that's my big picture drug overdose stuff and some of the stuff that's been going on with fentanyl that I've been following my career. I have more comprehensive reports online that I'll send out the links to afterwards. But I just wanted to transition a little bit about how I got here and some recommendations for success, because I know that there are a lot of students. So I think Sam mentioned that I'm from Nevada. I got my undergrad and my master's degrees at University of Nevada, Reno. Did my internship at the Washoe County Health Department, working in STD surveillance, treatment, and prevention. But when I got to graduate school, my internship was at the Nevada State Health Division, working as a communicable disease epidemiologist. It's really interesting to see. And I did my graduate thesis on H1N1 influenza incidence and vaccination rates. There was a couple different tracks in my graduate studies. I was more interested in data analytics and epi and bioinformatics rather than, the alternate kind of paths. And so I was really happy to get that and then to get this job too, because it's a very, very data heavy position. And so within about 6 months, I moved out here for this job and I love it. And so, like, big picture of my daily work, I put out a drug overdose report every quarter. There's some maps, some different graphs to have some tables that you can download and look at different localities, and it's kind of open source. So people, if they want to download it and look at different things, we do an annual report. It's a snapshot of all of our deaths for that year and kind of divide it up. I'm published to have done collaborated on a variety of different formal publications on gabapentin suicide, drug overdoses. We've done publications for VDH, both external for the public, as well as some big papers for the governor's office and such on mortality. Done a lot of media interviews, again, just because people want statistics to add to their story. So I get to fill those a lot. Done presentations to legislators, community groups, a variety of different people if they're interested in some statistics. I try to provide that for them. And then just because if you are going down the epi path and you're going to be doing, or biostats path, you're going to be really heavily in software to use data or to do data analytics. So these are the software applications that I use frequently, all Microsoft Office applications. I was trained in SAS for grad school, but use SPS for this position, and I'm kind of transitioning out of that now, but that's kind of a process. GIS, if everybody doesn't know, it's a mapping software, so you can map a lot of different things. Microsoft SQL Server, I'm going to talk about that on the next slide. Tableau, and R Studio. And so my last slide here is my recommendations for getting started in public health and being successful. I strongly encourage that people be willing to relocate. When I got out of school, I was very dead set on trying to stay on the West Coast, either in Nevada, California, Washington, Oregon kind of area. And I applied for literally probably over 200 positions. I'm not even joking, with experience. And I was so upset about not getting jobs. I'd get a couple interviews, but I wouldn't make it to the second interview. So I really opened my door, and I know I was being very picky with what I was applying for. So that's part of that. But I just wanted to emphasize that if you have the capacity or the willingness and to relocate, I highly, highly recommend kind of opening the doors for that, because there's so many opportunities out there. And when I started searching and did a kind of a nationwide search for this position, or nationwide search for a position, I ended here. So this really worked out for me, and highly recommend that to other students. And it might be hard to get your foot in the door at first, and be persistent and optimistic. Use each job interview as a way to get better for your next interview. And I'm very guilty of the first one. I really got bummed out and was really kind of down on myself when I was struggling to get a career started. But just it will happen, and it will be the right thing. So just be persistent and optimistic. It's essential to become a good writer in public health. A lot of people can't really interpret a lot of graphs and visual images, and so it's really good to be a summary writer and be well spoken and well written with good grammar and spelling. Very, very essential. And public health skills can be applicable to other fields of study. A big piece of like the epi part is data analytics. And if you think about that, of course, public health, that's very strong, but there's a lot of other different avenues as well. Computer programming, you could work for a bank. You could do data analytics for, a big tech company. It's very good, a well-rounded kind of education to be able to kind of pursue further within your career and become better or learn more things. And if you want to go a different way, you can. And again, if you're going to be going into an epi or biostats field, definitely recommend learning some software. This will set you apart from the rest, and it will get you very, very good results. And when you apply for jobs, I think people will definitely be calling you back. Our studio, it's advertised as the best software package for statisticians and researchers. It's free, it's open source. I'll be honest, I have had a challenge learning R. It was not easy for me, but the health department is really pushing to learn R because it is such a good program. It's difficult to learn, but highly recommend. Tableau is another program that I highly recommend learning. It's a data visualization software program. So like you can put your data in there and make these interactive dashboards where people, you can embed them into your website. People can go in and, they only want to look at Richmond, or they only want to look at females. They can pull out all their own data, and so it's interactive. And Tableau, I think, is relatively easier to learn. Definitely highly recommend that. Python is kind of similar to R. It's a general purpose coding language. It's a lot of power. That one's free and open source too. If you're going to learn Python, it might be for other purposes too. I think Python's used in a lot of computer programming. I'm not too knowledgeable about Python because what I wanted to do was to go after SQL. And so SQL is a relational database management program to query and manipulate your data. And this is the one that I highly recommend. So essentially, when you learn to program, you'll have a database and you want to be able to pull your own information out. And so, front end people, when they're taking, we'll use my database for an example. People, our death investigators will take calls and enter all the information on the front end of the database. Well, for me, I need to know on the back end what's going on so I can pull and analyze my data. And so that's what SQL does. It connects to your database, links everything together, and is able to extract the information that you need. And I personally, this was the easiest to learn. It is applicable to so many other positions. I think people at the health department might tell you to learn R Studio first, but my personal preference is SQL. So, different differences of opinion. And that's all I have for today. I'm happy to take any questions, or if anybody wants to email me, I can definitely give Sam my slide deck if you guys want some of the links for the reports that I do, or you can just go to our website too with a variety of different things posted on there. So it's just vdh.virginia.gov/medical examiner.
Awesome. Awesome, Rose. Thank you so much for your presentation.
Yeah.
I just have a quick question. So I did a study design on opioid overdoses in West Virginia last year. And I'm just interested if the way Virginia is set up, I know you said every state doesn't have this and they don't have the same regulations. Is that correct?
Kind of. So it depends whether they are a medical examiner or coroner system. I want to say West Virginia is. I am not sure if they're coroner or, but anyways.
I believe they're a coroner system. So I guess my question is, so just in Virginia, you all manage how those deaths are qualified and filed. Whereas when I was doing my research, I really had to look up ICD codes, and it was kind of dependent on who put that information in the system. So I found a lot of fluctuation in the reporting. I just wanted to know if Virginia is the only state really set that way, or are more states regulated the same way?
I was going to bring this up in my presentation, but I did not know how detailed you wanted me to get. And so there's a couple different sources. So we are a medical examiner system here in Virginia, but every state has the vital record system. And so death certificates are filed through this electronic, we file, or we complete most elements on a death certificate for our cases. That goes into a national database. That database then goes up to NCHS. They clean and code everything, and it goes back to the states. There are some jurisdictional differences about the cases we take. There are substantial coding differences because OVR, Office of Vital Records, uses ICD-10 codes, which is the national standard. We here at the OCME have an internal coding schema. So there are, in the way that we report things, OVR only uses residents. We use people that die here, and that's just in code. And so I would say that for the most part, medical examiner systems or states that have medical examiner systems are very similar to my position in the way we report deaths. But if your state is using OVR or vital statistics numbers, those are going to be different. They're still correct, but just different than what we have. So I think that that's probably what you ran into in West Virginia, perhaps, because they were using OVR. And we do have OVR presents a lot of, they have a dashboard and everything through VDH. It's just, it comes all down to different methodology and jurisdictional, or how we define cases. And so there is some difference there.
Awesome. Awesome. Thank you so much. I appreciate that.
Yep.
I had a question too. I mean, I thought this was really fascinating. Seeing the chart with the drug overdoses, I knew it was a problem, but I didn't know how much growth there had been. That was crazy. And my question is, what can you tell us about the demographics of the overdose, especially the opioid overdose victims? Is it more concentrated in the younger, or is it more spread out across age groups? Is it more concentrated among Black or Hispanic, or is it more spread out across racial groups? Any sort of demographic insights would be very interesting.
Sure. So up until about 2019, white males had the highest rate of overdose. So there's, we have to use rates for these, right? Because the population is much different. So up until 2019, white males actually across the state had the highest rate of opioid overdoses. But actually, it might have actually been in 2019 is when Black males actually surpassed white males as number one. And the growth in Black males for opioid overdoses has just shot up astronomically, even to this day. So I want to say the last we looked at it, the rate's about twice as high as what the white males have. If you just do graphic male to female, 2 to 3 times more males die of drug overdoses than females. The age kind of has like the age of overdose deaths really kind of peaks around 24 to 45 or so, or 25 to 44, that age category, especially with the rates, and then kind of tapers off. But we do still have overdose deaths in the 80s, people in the 80s. We have, obviously, unfortunately, children that get a hold of medications or drugs, and they unfortunately overdose as well. So it's kind of on both ends of the spectrum, but the peak's really kind of that 24 to 45.
Yeah, thank you. And is there any sort of rationale or explanation for such the huge spike among the Black population?
No, and I sit on a lot of national calls, and I've brought this up over the years and asked a lot of questions about, like, is anybody else seeing this? CDC put out, we started seeing it, it was like 2019, I think it was 2019 when the shift changed. And CDC put out a publication a couple years ago, but and a lot of people were saying, well, it was all, COVID or the unrest of the population, but that wasn't true. We saw it in 2019, and I don't know what the answer is. I'm wondering if it has something to do with, the different types of drugs that people use, and now fentanyl's just making it into those drug supplies. Cocaine specifically, if you look at cocaine over the in the past prior to the increase in fentanyl, was predominantly among Black populations. So I'm wondering if, the fentanyl's gotten into the cocaine and is kind of, unfortunately, affected them. I'm not really sure. It's definitely something we've seen, but I haven't seen a good rationale of why, but multiple states are seeing the same thing.
Yeah. Anything that is changing, hopefully, that might make an impact and lower some of these deaths?
Nationally, I think that there's still over 100,000. I think we may have plateaued. It looks like we might potentially have a slight decrease, but it's, minimal, not anything crazy this year. But there's been a lot of effort. We've sat on a lot of different, as the health department, or my office has sat on a lot of different efforts to try to combat the drug use. Narcan was saved so many lives. That's very widely distributed now. They're doing the fentanyl test strips, hearing about that, like testing, making, and kind of a lot of public awareness campaigns about people. A good portion of our drug overdose deaths are people that die by themselves, locked in a bathroom, locked at home. And so the shift is to, if you're going to use, of course, we're saying don't use drugs, but if you're going to use, don't use alone. Carry Narcan. But I don't know if there's, and until we can control the trafficking of the drugs into the United States, I don't see this going down substantially. Unfortunately, it's just, you see the fentanyl just, increasing in drug seizures, and then you're seeing it in stuff of the Customs and Border, and the interdictions through the USPS, and it's just, until you cut that off, I just unfortunately don't think that we're going to see a substantial decrease.
Sorry, and last question, do you know, since Hampton Roads is such a major international port, is it coming through our port? Are we a port of entry?
Yes, correct.
Okay, thank you.
Uh-huh.
I had a couple questions. You were talking about how you use media to your advantage. is that like to get information from the public? Is that what you meant by that?
No, just to get information out. There's been a lot of media campaigns, especially around drug use, and like we can just use drugs for an example. It's just, telling people, like for example, we've had like a rash of overdoses when this all started. There would be like in Henrico, there'd be 10 overdoses, 4 of which died in like a 2-day span or something. And so law enforcement would, or we would call law enforcement, we kind of collectively work to put out a press release, or to have the local media stations, say something about like there is a very potent drug out. Just kind of things like that to notify people. I think that that's a little bit, and at the beginnings kind of started working against, so because people were actively looking for stronger drugs, but just putting the message out there. We've done a lot of campaigns for drowning around Memorial Day because it's when the pools open up, so I've given out information and coordinated with some statistics and the types of people that have died. Just try to make sure that the public is aware of what's going on in some numbers and kind of make them aware of different things.
Okay, cool. And then, so you're the only state forensic epidemiologist.
When I started here, I was one of maybe 2 or 3 across the country, but now it's been 10 years. I've seen that group grow. Was involved in a CDC group that was kind of trying to coordinate all of the forensic epis across the country. So it's definitely something that's coming, up and coming.
Yeah, that seems overwhelming to be the only one for the state though. Like, do you think that they're gonna get more? Like maybe it'll be like an area thing or
Well, just because I guess with the data that I work with, it's not
like
as,
statewide?
yeah, so it's just statewide statistics. We're definitely building up our Division of Death Prevention group that I told you about, that there's multiple people that fall under that category, and they are, cleaning data. I think that they're hiring, like I think I mentioned, hiring for an epidemiologist to oversee a couple of those programs and do the data analytics. So that program is growing. I don't know if my position, if we necessarily need anybody else, but I could definitely see with the grants and some of the stuff that are being requested by the General Assembly to do, to build up the DDP group.
Yeah. Thank you so much. If nobody else has any other questions, you actually answered like 85% of my questions that I had for you before we even came in here. You did a really great job.
Oh, awesome. Yeah, thanks for having me, guys. That was good presentation. So I hope you learned something, and I will send out the slides to you, Sam, if you want to
Yeah,
send them out to anybody.
yeah, we'll disseminate it. Yeah, and a bunch of people said thank you in the chat.
Oh, awesome. Yeah, thanks for having me, guys.
Yeah, thank you. Have a good day.
Okay, you too. Bye.
Bye.